Good morning, everyone. Welcome to We're All Patients podcast. Today's guest is someone who has spent her career turning passion into real, measurable impact in rural healthcare. Toniann Richard is the CEO of HCC Network, one of the few rural health networks in the country that operates multiple federally qualified health centers. Since 2007, she has led the organization from a two-person operation to a team of over 130 full-time staff, supporting a 15 million fiscal impact, all with one mission: closing access gaps and delivering quality care to underserved communities. Toniann has raised millions in grant funding and built a sustainable model for rural health that integrates everything from critical access hospitals to behavioral health, public health departments, and community clinics. She's also a fierce advocate for the workforce behind rural care, tackling issues like burnout, specialist shortages, and the challenges of recruiting and retaining providers in rural communities. With over 25 years in nonprofit leadership and service on numerous boards, including RHI Hub, Missouri Primary Care Association, and the National Rural Health Association, Tony brings a wealth of experience and a deep understanding of what rural communities really need. Toniann, welcome to the show.
Good morning. How are you?
Good morning. I'm great. I'm so grateful to have you on. You're making a real difference in rural communities, and I can't wait to hear more about it.
Great. Glad to be here. Thanks for the opportunity.
So let's jump right into it. The whole topic or name of this conversation is essentially affordable red carpet care. What is your vision for what that means?
So, that's a phrase that red carpet care is something that we've talked about for a long time. Actually, my COO, Amanda Arnold, you can hear her say it on any given day. And really, when we started out as an organization, we wanted to make sure that we were treating people as if they were, walking down the red carpet, no matter what service they were looking for, no matter what their needs were, no matter their social or economic status. We wanted everybody to feel like their needs were our main priority. And I think that that's been the heartbeat of what we have done over the years. And it comes out in so many different ways. Our financial indicators are strong. Our quality metrics continue to improve. Our patient satisfaction is in the upper 90%. So just setting that mentality throughout in our entire organization and throughout our board as well was a priority. I want to preface this with, we don't always get it right. Like I shared with you in preparation for this podcast, we've learned more through the things that we've done wrong, or our missteps, or just those ouch moments that we look back and say, oh, shoot, I didn't do that so well. How do we do it better next time? And it's actually one of the things that I pride myself so much in leading this organization and these tremendous staff that we have, in recognizing that when we have a misstep or we have an ouch moment, that we're not afraid to talk about it and do better. We can't fix everything. There are certain things that just are the realities of rural healthcare. We do not have the resources to provide cardiology in our clinic, but we do have the ability to work with tremendous partners to do referrals to cardiology. So just recognizing that we can't be the end all be all the time, but if we're doing business right, we should be able to bring people to the table that can help.
Nice. Well, it sounds like everyone deserves the best care, no matter what their background.
Mm-hmm.
And you're willing to learn from your mistakes, which is awesome because, you know, there's always the shove the mistakes under the carpet and pretend they never happened
Right,
thing
right.
that people, that plenty of places do. And yeah, you can't really improve things unless you actually, you know,
Know about
essentially
that.
look at the tape
Mhm.
essentially, right? And uh, make adjustments.
Yeah, absolutely. And I think, we've also, like many organizations, have had the mentality of there's no wrong door. Um, there's no wrong way to get into our organization to seek care. And I think that's really important. But I also think that there's another conversation that is about there's no wrong location. Also, so it might be that a patient gets to us through the emergency department diversion program, for oral health. And being in good communication with our partners and, working with other organizations in the communities that we serve, knowing what services are available, doing our best to make sure they understand who we are and what we do is is really important and really critical. Um, we at rural communities, whether it's your hospital, rural health clinic, your school districts, your municipalities, everybody is practicing at the top of their scope every day. Even in my position, I feel like there's so many days that I think, whew, I I need help. Like I've kind of hit the top of what I know about a subject or a topic or an issue. And I've been really fortunate to be surrounded by people that are a heck of a lot smarter than me. Um, and just being able to say, how do we solve this problem together, as opposed to how does HCC solve this problem? That problem solving is likely going to include many other organizations. The pandemic is a great example. Our health department was like many health departments in rural communities, specifically in the Midwest. The resources were already thin, and then you have a pandemic that hits. They're already short-staffed, low supply, low volume, low funding, and we had the ability to step in and provide, a lot of help in that space alongside our critical access hospitals and rural health clinics. So just recognizing that in rural communities there isn't a one-stop shop, and no wrong door, is a great mentality. It just for us needs to be a bigger purview of just one facility or one organization. It's got to be, in partnership with others.
Yeah, something we're not taught very much in school or
Hmm.
other places as far as uh, work learning how to work well with each other and not competing because it's
Right, right. So, the competition looks really different, um, for us. Now, don't get me wrong. Competition still exists in rural communities. Um, I just think that rural communities that recognize where those gaps and weaknesses are, definitely helps provide more sustainable services, across the board. You know, if a hospital closes, and if one of our hospitals were to close their doors, it would really strap us. I think I think you came across my information through, Heidi Lucas at our state association, and she and I've been, along with many others, been working really hard to beat the drum of save rural hospitals and the implications of, um, Medicaid cuts, Affordable Care Act plans reduction. And I actually had somebody say to me, "Well, Toniann, why? why are you spending all of this time advocating for rural hospitals? You guys aren't even a hospital. And I said, well, I mean, great question. Let's talk about that. Let's talk about the rural ecosystem and how if one of us folds or one of us goes down, there will have to be people who step in. There will have to be people who provide care, and there's just not enough resources already. And so it is always in our best interest to keep our rural health clinics and our mental health organizations, and critical access hospitals and rural hospitals alike, in business and thriving. So the ecosystem just looks different. I also think that you bring up a really good point about we're not taught that, and we're not. And I look back on some of my former positions and careers before I got into healthcare, and it was very cutthroat. I worked in what we used to refer to as a man's world for a long time. I sat around in a table of executives that was primarily men, and it was the conversation looked a whole lot different in a larger or very much significantly larger organization, and it was all about competition. Whose facility was doing better, and who was your high performers, and how are you recognizing them? I'm not taking away from that. I certainly think that competition keeps us growing, and we get better. I'm just not really a fan of survival of the fittest models, where one wins and another one loses.
Well, especially you mentioned in rural healthcare, there's not enough to go around anyway. So
Mm-hmm.
in that kind of system, if one fails, I mean, that doesn't help anyone really, because that just hurts the patients, if anything.
Right.
So how let me rephrase that. How have you been able to kind of look beyond what where everyone else kind of trips, and see the value of collaborating and actually expanding access,
Mm-hmm.
and seeing the big picture of it all?
So our story is very unique in that we started out as a rural health network. We actually had no intentions 20 years ago of even opening a brick and mortar clinic. And because of how we were founded and developed, it was as an organization, our primary mission was to respond to the needs of the community. And our board at the time, and continues to this day, to be very responsive, quick moving. One of my favorite things about our board is that they are highly intelligent risk takers with a plan for a safety net if said risk would fall through. And so we definitely have always had the opportunity to do new things and to try new things, and not be afraid to say, well, that didn't go so well. What do we do? Do we run it through a PDSA model? Do we plan, do, study, act out of the IHI organization? Or do we abandon? Do we fish or cut bait? What do we do here? So, we were founded on a very different platform, if you will, of responding to community needs. And at the time, hospital CEO was on our board, and there were a couple of rural health clinics in the community that were at risk of closure. And this has been over 10, so about 12 years ago, 12, 13 years ago, they were at risk of closure. Reason being, they were a hospital-based rural health clinic system, and so the finances were clunky and complicated because of the overhead allocation, and how patients are counted and how finances work, which I'm definitely not an expert in, but he was and continues to be, and said, hey, we've got these two communities. One of those communities has less than 1,000 people that live in the community. So we're talking a really small community, and the clinic was one of the largest employers in the community in that area. And he said, I don't want to close it, but I also have to make the best decision for our organization and for the hospital. And I believe under the FQHC model, the community health center model, these are both sustainable clinics. And so overnight, we basically assumed operations. And so we were fortunate in that we were able to transition 100% of the staff and patients over to the clinic. So we weren't building from a true 0-0. However, we did not have an FQHC designation. We were actually, Medicare was so confused about who we were. We were a nonprofit rural health clinic designation with a dental program tied to it, and because our immediate need was dental. And so we had CMS so confused about who we were, and we were applying for FQHC status in this same time frame, and just praying that things would come together and that the resources would come in, because we did not have a reserve. In fact, I recently just told our dentist, who has been with us for over 10 years, I said, yeah, I think we had about $10,000 in the bank when we took over that clinic. And looking back, one of our old board members said, man, it sure would have been nice if we had another 0 at the end of that to get started. But we knew that if we just kind of put our head down, stayed the course, and that things would come together. And it did. And so we came to fruition a little bit different. A few years after that, we were able to open 2 more clinics. Eventually, now we have 6 locations, a couple of mobile units, many outreach locations, as well as a pretty significant footprint in the reentry, probation and parole, incarcerated individuals population as well. And so alongside of that was our local hospitals engaging. And in fact, we shared staff with all 3 of the hospitals that were in our service area at the time that we had just the 2 clinics. And so we were sharing staff. The referral patterns that we set up early on out of the before we opened the clinic, we were working on an emergency department diversion program, and it was really specific to people with diabetes that were unmanaged diabetes. And so we were already doing some of that in the works, where we were just trying to get people assigned to a primary care physician as opposed to using the emergency department. So we were able to duplicate a lot of those ideas around the workflows. And one of our most successful programs early on was the dental pain diversion program that we did with our emergency departments. And one of the major reasons that worked out well is we were sharing staff. And so we had staff that were working in the emergency room at these hospitals, or were rounding on patients, or had a clinic of their own, and then they were working for us very part-time. And so getting them involved in the early days was really critical to that. The other thing we did was our local public health department was actually an original founder of our organization, along with the critical access one of the critical access hospitals, and then a community mental health center. And so we were also sharing staff with the community mental health center because we had zero capacity for mental health in the early days. So we were able to share some staff with the community mental health center, and then eventually with the public health department as well. So just really being open-minded about integrating people and services, and not trying really hard not to duplicate services. Missouri is an expansion state. We expanded Medicaid a little bit differently than most of the states. So we are a ballot measure state. And as part of that ballot measure, adult Medicaid or adult dental Medicaid was part of our expansion, which allowed dentists, private practice dentists in our community, in our state, actually, to start accepting Medicaid.
Wow.
And get paid a more fair price for taking Medicaid patients. That was a huge win for our organization, for the state, because we still need more dentists. I mean, even though we had multiple dentists that were employed and we were sustaining through other grant resources and things for adult dental, having that billable service was great for us, but also great for our local dentists. We also, in one of our communities, there was a dentist who had just started his practice and wasn't really busy. He was taking over a private practice from another dentist, but they were going to work together for several years. We were actually able to bring him on as our dental director a couple days a week to see patients and provide us some dental leadership while he was building his private practice. That's pretty unheard of, that you're actually promoting a private practice, competitor in that space. But we knew that we would never be overstaffed in dentists in our communities. And the expansion of Medicaid allowed for more dentists to be able to take Medicaid patients. With the Medicaid cuts, I'm fearful that they will decline. Those reimbursable services they are threatened. And we will be going backwards to where private practice dentists are unable to take Medicaid because they just can't afford to do it, which is fair. So we'll have to work through that.
So it seems like that gap either will have to come from the federal government somehow in the future, like legislation or something like that, or at a state side, essentially more money will have to be provided by the state in some way.
Mm-hmm. Yeah, and we could do a whole nother podcast on Medicaid financing to add another layer of complexity, because Missouri did expand Medicaid through a ballot measure. It's going to get a little weedy because technically the state can't change that without undoing the pass of Medicaid expansion. Now they cannot fund it. I mean, it's still, they can reduce the funding, they can cut the funding, those types of things. But to just say we are no longer providing coverage for our expansion efforts because it was a ballot measure, it would have to go back through the legislative process.
When you were talking about the dental piece of things, I remember back in the day when I was in internal medicine residency, and we had a patient in the ICU. essentially that when the patients essentially end up in the ICU from a toothache, from just a toothache that's
Right.
just was never treated, right? And then becomes then the tooth it becomes infected, the infection spreads, it becomes septic, and you know they come within an inch of dying essentially, and all because they didn't have the money or the resources to go
Have it pulled or
yeah
taken care of early on. Yeah.
mm-hmm.
The, I mean, that's a, that's a big problem. I mean, people delay care, because they need money for groceries or, clothing or housing. And, that's, you and I talked about social care, and social determinants of health, and how health centers, hospitals, social service agencies, the visits people come for they're changing, right? So it's not just about coming to the doctor or the dentist because you have a fever. It's in that visit, because we are asking questions about, do you have housing? Do you have transportation? Our community health workers are picking up, like many organizations that employ community health workers, we're actually going to patients' homes to pick them up, bring them to not only appointments with us, but appointments that are in Kansas City, that is a transportation barrier for them. We're talking to them about, do you have food at home? What if a diabetic, what are you eating every day? Why I can't afford the food I'm supposed to eat, but can you? So let's talk about that. Let's actually sit down and have a conversation about how can we make this work, or what resources are available. And so we're fundraising essentially for some of these needs of patients that are not provided by WIC or SNAP, or TANF, those types of things. Are we required to do that? No. However, is somebody going to meet their health outcomes if they're worried about these other things? Absolutely not. And so to me, that is part of that red carpet care. And it's a part of just sometimes even just having the conversation. So where's the knowledge? Where's the knowledge is power, with people? Yeah, you might be able to get that, 99 cent. I don't even think they make 99-cent cheeseburgers anymore. It's been so long, but back in the day, when you get a 99-cent cheeseburger, you might be able to do that 5 times a week. But for the same amount of money, you could probably get 5 apples and a small thing of peanut butter that would provide a much better nutritious lunch or snack or whatever. And so having, just being mindful about sitting down and having those conversations. I also don't want to lose sight of the addiction and recovery piece. We are not a community mental health center. We work with some tremendous community mental health centers, but this is another space where there's just not enough. There's not enough, providers in rural communities around addiction and recovery. We're constantly trying to recruit for that. The peer model, it works. And we employ, I think, 6 or 8 peer specialists, and some of those peer specialists work with our incarcerated probation and parole folks. Some of them work strictly with drugs and alcohol abuse, but that peer model of, hey, I have lived your hell, I've lived your experience, let me walk alongside of you to do it. And they are peer coaches, community health workers. I always get nervous doing this because I don't want to leave anybody out, because I think everybody is a really important part of the systems, that we work here. However, community health workers and peer coaches have to really get on a whole nother level with people. That vulnerability of, I've been there, I've done that, I want to help you. And the fall down, get back up 6 times versus 7. You have to have a lot of patience. And our peer coaches are very busy. They're very committed. It is a very difficult job, because you're talking about their vulnerabilities as well, right? So you have a vulnerable patient, client, but then you also have a worker who's dealing. I don't care how long you've been out of recovery, you're still dealing with the trauma of that. And so putting yourself in that space every day. Community health workers, constantly sitting in an office or an exam room or a lobby of a coffee shop or something with a patient that is opening up to them about, I don't have any money to pay my rent this month. And so, no, I can't afford to get my insulin, or I can't afford to take my medication. Those stories that they hear over and over and over, it's just an exhausting place to be. Neither of those positions are reimbursable in the state of Missouri through the FQHC program. And so that's another space where we have to secure additional funding, whether that's through a grant program, whether that's through our federal or state money, et cetera. So finding the resources to provide the wraparound support, the red carpet extras for people in these situations is a huge undertaking for organizations, because not everybody wants to fund that, right? So your outcomes aren't always fantastic in that space. They're hard to track. If you are tracking them, they're difficult to validate. And so you have to find other ways to prove that it is a worthy investment, if that makes sense.
So you have to show that it's essentially, if the state is giving $1 million towards it, that it's returning them $5 million in reduced healthcare spend, or what have you, essentially.
Yeah, it's not quite that scientific, but it's under scrutiny a lot. As we all know, state budgets are super vulnerable right now as well. And so every investment is being monitored or looked at on a lot of different levels. And so it's not always about the money back or the health outcomes. It's usually a combination of both. But the data isn't, because it's not a billable service. It's not like we have claims data. We have data in our electronic health record, but not a health record doesn't capture everything. And so it's just challenging at times to tell the story of the impact, unless you're just sitting in a room telling stories, which is very important, but doesn't always make it to a funding report. We have been very fortunate in our service area. We've got several fantastic foundations that have funded new and existing sustainable programs. There's parts of our state that are not covered by any foundation. And so I know people that are in those areas of the state really are challenged when state funding is cut or federal funding is cut. Finding an alternative resource to cover some of that stuff is more challenging than where we are. We are seeing a lot more of the public-private partnerships coming together. More foundations are coming together to share some of the load, getting strategically aligned. And so it'll be interesting to see over the next couple of years how that continues to grow.
That's interesting. So you're saying that there's kind of maybe private companies are stepping in to some degree to kind of help bridge that gap that's left, without state or without federal
Right.
funding.
Mm-hmm. Yeah, so I had the opportunity earlier this year to attend and sit on a panel in DC that was a venture capitalist conversation, which was a whole new world for me. But so venture capitalists, investors, attorneys, banks wanted to know how they could better partner with foundations and nonprofits in their community to provide investments, and what does that look like? Because obviously VC investor is, they usually want their money back plus X within so many months, days, years, whatever. And nonprofits obviously don't work that way. And so how do you have the conversation that says, hey, we at company X want to invest in an organization, a healthcare organization, and they don't want their money back, but they do want accountability. So it's not just a flat donation. It's a, hey, we're going to make a, kind of where we came out of that was we are looking to make a 5-year commitment to organization X. And in that time, it's renewable every year. However, these are the top 3 indicators, or the top 3 metrics that we're going to be looking for. And so they could cancel that financial commitment at any given time if there wasn't a performance. And that's new. That's new for people in nonprofit that have historically fundraised based on their history of performance. And so a lot of times you'll go to a big gala for an organization, and you might have a bank that's a premier sponsor, and they're sponsoring maybe $50,000 towards that organization, but it's based on their previous performance as an organization. They served X number of people in the previous year. This was their health outcomes, not necessarily looking forward to say, hey, we're going to make a 5-year commitment, and every year, here's the reports that we want, and your funding is contingent upon that. So they're kind of acting as a foundation, but also an investor. They just don't want their cash back.
Wow. Well, that's cool though. I mean, accountability is good if they're tracking the right metrics and right, if it's the right metrics and the right expectations.
Right. Well, and I think that the whole public-private partnership, we're also seeing it in the federal grant space, along with a national organization called Grant Makers in Health. They're pushing some of these conversations too about what are foundations doing in their communities to bring together different types of investors, whether it's through the money then goes to the foundation and it's matched with a grant, or if it's a giving directly to an organization, just really cultivating relationships and forming relationships and partnerships with nonprofits, granting organizations, as well as private funding.
And so it sounds like that's something you're looking more into as time goes on, especially these days with federal funding being, not can't trust it to be there forever. So
Right.
And obviously with the cuts, so are it seems like people in at least the federal government aren't actually seeing or at least realizing what they've done yet,
Right.
because they think it's more of a political what's the word, like
Sure. Hmm.
politics basically, rather than the actual statements that are, hey, like these hospitals are going to go out of business. Not
Hmm.
just politics, it's actually going to happen. Like,
Right.
no one's threatening, people aren't threatening hospitals going out of business
Hmm.
so that so the government wouldn't cut funds. They're actually saying, hey, this is what's going to happen if you cut funds.
Hmm.
They cut funds. Now we're kind of staring down at that black hole of of what might happen. And so private funding, VCs, it seems like, are kind of seeing that and are
Hmm.
starting to talk with people like you to
Right.
move the needle.
Yeah, I think a lot of the planned implications to the healthcare system financing model for hospitals, it's first of all, it's not easy. I mean, there's healthcare economists for a reason, and um, some of the very best in our country have put out some, significant data on why these issues are going to be major for rural hospitals. Um, and I think the idea of hospital closures, we've been talking about hospital closures for a while now, and they are happening. Um, but I think the idea of it speeding up hospital closures was sort of a, well, that might happen thought process. And now we're already seeing in rural communities, before the cuts even happen, we see hospitals making significant changes um, to their care delivery and the services that they're able to offer, because they have to prepare for what's to come. I also think that there's a lot of our lawmakers and legislators that are going back and saying, wait a minute, did we have all of the information that we really needed when we were making some of these decisions? And um, my role as a healthcare leader, and um, some of the boards that I serve on, we've really all kind of taken this position of, we have to step in and educate people, educate our legislators, our lawmakers, their staff. I cannot stress the importance of educating congressional leaders' staff on really what is happening boots on the ground in their communities, because a lot of times it's, they're drinking through a fire hose too, of processing information. And so figuring out who in their office can break this down and have it not feel like a veiled threat, have it be, this is reality. It kind of goes back to our original conversation of, I saw something recently that said everything is figure outable. And I think there's a lot of truth to that, but I hope that our leaders are taking a minute to digest information that is being shared, and recognizing that it's okay to go back and make some modifications and make some changes to the information or the plans going forward. Reason being, they've received new information, they've received new data that is going to influence those decisions. And so I hope they keep red carpet care in their mind too, about certainly reducing the number of hospitals, reducing the number of clinics, access points, mental health, etc. in your community is the exact opposite of red carpet care. So
I like how you said everything is figure outable.
Mhm.
There's the founder of Theory of Constraints, Ellie Goldratt, I think, said things are um, complex, not complicated.
Yes, for sure. I like that.
Yeah, so it's which makes things easier to kind of digest, right? It's like, okay, so it's there's a lot to it, but it's not.
Right.
There's a lot of threads there, but
Hmm.
you just have to, you can kind of follow each one and get to the end.
Absolutely. Yeah.
So educating the lawmakers, I mean, sounds like a great idea. It's um, to your point, yeah. I mean, of course, they are, I'm sure, overwhelmed with information anyway.
Hmm.
It's healthcare is just one of the things they have to think about, and it's not. Um, and they have to rely on the opinion or the information they get from the people they trust, which may or may not be complete. So um,
Yeah. I also think that um, healthcare, a lot like education, municipal government, decisions just can't be made in a vacuum. There's so many factors that fall in, push out, and if you're not having really good community based conversations with your other systems, um, you're you're missing pockets of information that will drive a better decision.
so do you have any? You mentioned that some lawmakers are kind of seeing, okay, maybe that wasn't the best decision given, you know, didn't, but I made it the best decision I had with the
Mhm.
information I had. Um, Out of curiosity, uh, is there a remote possibility that some of those cuts could be reversed?
That's a great question. Is it possible? Yes. I think midterms in 2026 are going to drive a lot. With the delay in some of the um, requirements for Medicaid, the healthcare financing through the states, through the provider tax. Some of those start launch dates are beyond January 1st. I think midterms will drive a lot of that. I I'm hopeful that our leaders have taken some consideration to even hitting pause on them as they do gather more information, um, and run some local statistics, local data. Um, if they're looking at everything from a national level, and not breaking it down into how it's truly affecting their district, they're getting watered down information, especially the leaders in rural communities. Um, and the data's there. The data's there. They can reach out to their hospital CEOs, health center CEOs, state associations. The data's there. Um, but if they're not taking a look at that from a much more micro level, then they're missing critical information that will directly impact the economics of their communities, the health outcomes um, in their communities as well. So we're really encouraging that. Um, National Rural Health Association, we are having a lot of conversations with lawmakers about what data drove your decision, and would you allow us to have a conversation with you about how this really will impact the people that live and work in your hometown.
So once again, it seems like collaboration between uh,
Hmm.
different healthcare entities could really serve to help better educate the policymakers to
Yes.
then better serve their healthcare facilities. Because
Hmm.
by yourselves, if you have different voices, it's going to be really hard to get the attention of policymakers versus if you're all kind of, or not you're all, if we're all essentially um, united in kind of what's needed in Missouri, what's needed in Ohio, what's needed
Mhm.
in different
Right.
states, um, and there's only one or two voices coming,
Mhm.
from healthcare facilities versus like, oh well, there's just enough QHC that needs something, but
Yeah, and making that ask, making or not ask, making that voice um, vertically integrated. So not having a single voice delivering the message, but it's got to be, you know, your hospital, your public health, your education people, and healthcare people need to think outside their box too. They need to be sitting at those education tables. They need to be sitting at those municipality tables, and understanding how federal funding attributes to state funding, which then attributes to county and city funding as well. And so, for sure, putting a vertically integrated group together is super important. I also think that we can't lose sight of the fact that if even if you reduce care, you reduce payments. People still need care. They still, most of the time, will get rolled into a system of some sort. And is that system best for them as an individual? Is that system best for um, are they the appropriate organization to be taking care of somebody? We can practice at the top of our scope all day long, but at the end of the day, there's certain things that people just can't do. Um, and then you open up just a whole nother issue, box of issues, Pandora's box, if you will. But what is going to be the response then when you've got this, kind of outcry of, hey, our homeless people, our numbers are on the rise, and there's nowhere for them to go, and they are sick, and they're not taking their medication. I'd love to connect you to a gal that does a lot of these same discussions around behavioral health and what she has seen, and how pulling away services and pulling away access to medications, how it's affecting communities, because it's not good.
well, Toniann, I know we're out of time, and I really appreciate the insights from how to collaborate with others, which I think is a topic that many of us can, well, at least I would love to learn more about again, because it's not often that you see it on the level that you're doing it at,
Hmm.
um, and just with the overall, because you have the overall goal of essentially providing the best care to everyone and anyone, regardless of their background,
Right.
ability to pay, etc.
Hmm.
And so I think through that, because you have that goal, then collaboration is just a kind of almost seems like an outgrowth of that because you have to
Right.
collaborate in order to accomplish that.
Hmm. Absolutely.
So I appreciate the insights and uh, thanks again for joining me.
You're welcome. Thanks for having me.